The examination of PID typically follows 4-5 steps. The first one of them would be local examination, neurotension sign, and neurological examination. Neurological. So in the local examination, it would be examining the spine at that particular, you get local spasm, tenderness, tilting of the spine to one side. On flexion, there is more pain, as we already told you. When he walks, he has got a lurching to one side. What about the neurotension sign? Neurotension sign is you are going to stretch the sciatic nerve to a particular extent so that the pain is exhibited. And the first of them is neurotension sign. Patient is lying supine. You take his limb, flex the hip, keeping the knee straight, and find out the angle between the bed and the thigh when the pain is increased. Find out the angle between the bed and the thigh when the pain is increased. So this is going to be called as straight leg raising test. The angle between 30 to 70 degree is the only one which is significant. Less than 30 degree, it is not significant because the sciatic nerve cannot be stretched. It is lax. More than 70 degree, anyone who can get pain. So it's a spasm. So only between 30 to 70 degree is pain. What about the next test? The next test is, you do the SLRT, you got the pain at 45 degree. Now you dorsiflex the ankle, keeping the knee straight. If you get more pain, that is called SLRT with forced dorsiflexion test. SLRT with forced dorsiflexion test. What is the next test? You want to stretch the femoral now. If the disc is at a high level, L1, L2, if the disc is at a higher level, then you make the patient lie down prone. You try to extend the hip. The person gets pain in the anterior part of the thigh. The person gets pain in the anterior part of the thigh. And that is called SLR. That is called a femoral stretch test. Femoral stretch test for a higher disc prolapse. Prone position, femoral stretch test. So this is PID, local examination, neurotension sign. What is neurological examination? Neurological examination means if you have a disc prolapse at L4, L5, the common root which will get affected is the lower one, that is L5. If there is a disc prolapse between L5 S1, the common root which will be affected is S1. Similarly, L2, L3, the root will be L3. Now, if there is a L5 S1 disc prolapse, the root affected is S1. So, which is the motor power which is going to become weak? It is going to be FHL, FDL, flexor hallucis longus and flexor digitorum longus. And the sensation you will lose on the lateral side of the sole of the foot. And the reflex which we are going to get depressed because of low motor neuron is going to be S1 reflex, which is less. Similarly, if there is a L4, L5 disc prolapse, the root affected is L5. The motor power will be lost in EHL, EDL. The sensation is very typical of L5. Lost in the first web space. Lost in the first web space. There is no reflex for L5. L4, the reflex is not there, but L4 is the anterior part of the shin of the tibia. We can take the sensation. L3 is the knee. L2 is the thigh sensation. L1 is the inguinal area. L3 we can also test the quadriceps power. L3 we can test the knee jerk, which will be depressed. This is about the clinical examination of PID. You take an X-ray. X-ray many times will be normal. At least in the acute stage, It will be normal. Only thing, there can be loss of lordosis as a protective spasm. Loss of lordosis as a protective spasm. In the later stage, the disc height might reduce in a PID. Investigation of choice to know that it is PID is going to be a MRI. So before we land up on an MRI, let us see what is this disc and what is this it prolapsing. So we got to know that the disc is made up of two components. So what are the two components of disc prolapse? Nucleus pulposus and annulus fibrosus. And this is the PLL. This is the cord and the root. It's only the nucleus pulposus which prolapses, not the annulus. The nucleus pulposus is a gelatinous hydrated material, and the annulus fibrosus is the fibrous tissue area. Okay, the central gelatinous hydrated material is the nucleus pulposus, which prolapses through a rent in annulus fibrosus. And then it can pierce the PLL and touch the cord. It can be like this or like this. The most common is on this side, which is called posterolateral, and this will be called as posterocentral. So posterolateral disc prolapse is more common than posterocentral. And the different stages of disc prolapse, if it is like this, it is called bulge. More inside is called protrusion, touching the cord, extrusion, and sometimes the disc material falls here like this. That's called sequestrant. So different stages of disc prolapse are bulge, protrusion, extrusion, and sequestrated disc. Once the disc is prolapsed, it can be posterolateral or posterocentral. Posterolateral can be two types. Now imagine my body to be the cord and the upper limbs to be the root. The disc could be posterocentral or posterolateral. And in the posterolateral, it could be above the root or below the root. If it is above the root, then it is called as shoulder disc prolapse. If it is below the root, then it is called as axillary disc prolapse. If it is above the root, it will be called as shoulder disc prolapse. If it is below the root, it will be called as axillary disc prolapse. And now in the MRI, we are going to find out whether it is bulge, protrusion, extrusion, pressing on the cord, pressing on the root, posterocentral, posterolateral. What is the treatment for PID? In the initial stage, when the patient has come with no neurological weakness, complete bed rest, analgesics, muscle relaxant, complete bed rest, analgesics, muscle relaxant, pelvic traction, hot water fomentation, local application of analgesia, muscle relaxants, pelvic traction, short wave diathermy can be given. If the pain is decreased, then physiotherapy is initiated to make the back muscle strong. When the pain is decreased, you can make the patient wear lumbar belt and move around. If the pain does not improve, say around 2 to 3 weeks, or if the patient develops a neurological weakness, then it's better to do an MRI, find out the disc, and then do the surgery. So what is the surgery done for PID? The classical surgery for PID would be called as discectomy. Discectomy is a classical surgery done. Now you might hear the terms like laminectomy. Now total laminectomy was the approach to do the disc long back. After a few years they realized that it's not required to do total laminectomy to approach the disc and remove the disc. You can get away by doing half the lamina and then remove the disc. So we had a surgery called partial a laminectomy and discectomy. Then we realize with good instrumentation and imaging that we can go in between the lamina and remove the disc without disturbing the lamina, and that was called fenestration discectomy, and maybe a little bit of the upper lamina, little bit of the lamina lower was removed in that. And nowadays we can put a microscope or an endoscope, remove the discectomy, so the surgery would be called as discectomy. Long back we were using chymopepine into the disc to make a discogram, chemonucleosis, but that is banned because of severe anaphylactic reaction. So MRI is the investigation of choice. Before the MRI came, myelogram was done where the root cutoff sign was seen. Similarly, as we told that the disc prolapse can occur in the cervical. So if C5, C6 disc is involved, the C6 root will be involved, and so on. The upper limb will be motor sensory deficit will occur. The surgery in the upper cervical spine is also discectomy. Mind you, the discectomy is done from an anterior approach in the cervical spine and from a posterior approach in the lumbar spine. So this is the overall treatment protocol for a disc prolapse. So once we are through with the disc, we know it's common in young people. Discectomy is the treatment, MRI is the investigation of choice, neurodeficit, radicular pain. We go to the next entity, and that is lumbar spondyloarthropathy or lumbar canal stenosis.